Hello?
I'm trying to attend a webinar.
This is Sarah. Thanks for joining. We're getting through a couple minutes of technical difficulty here.
Okay.
And can you see the PowerPoint slides?
Cars, so I am just listening.
Nice. Okay. I hope you're pulled over.
I was pulled over while calling.
Okay. Let's get started. Thanks everyone for bearing with us. We are going to mute you while Dr. Gibson is doing the initial presentation. You can type into your chat box if you're at a computer. You'll see that in the upper right. And click the option to send to everyone. That way we can all see that pops up for us, and Dr. Gibson will know to address the question. Oh, if you could selves, we appreciate that. And we'll let you know if we're having any audio issues on our end, and you please unmute and let us know if you're having issues on your end. We're recording this, so you know. And I know we still have some folks joining. Again, this is Sarah. I'm at Maternal and Child Health here at the Health Department. Thanks for joining us for this technical assistance opportunity with Dr. Gibson. I would love to do a roll call quickly right now so we can know exactly who's on the phone. I know some of you have typed your names in. Others are kind of showing up as call-in users. So please unmute. And I'm going to call out by agency. You could just give a quick shout if you're on. From UCS online yet?
John Cross.
Thank you. About youth services in Windsor County. Windham County Youth Services.
This is from Windham County Youth Services.
Hey, Sarah, thanks a lot. I think Lund was able to attend. Kelsey or anyone from Lund? Okay. We have Ms. Faisa, thank you, at AALV. I know you're there. Freddie, Rutland Boys and Girls Club. Okay. Northeast Kingdom Community Action. Here at the Youth Services Bureau. And I think I saw Laura.
Yes, here.
Thank you. Child Center, Melanie. Okay, and Bristol Hub, do we have Ryan or Brian? Oh, maybe joining in late, and that's just fine. I'll probably do a quick roll call at the end. We have a very post test for you that I will email out after the webinar. Just a chance for us to know what's happening and who was able to join us. So I will hand things over to our lovely partner here, Dr. Gibson at the UVM Medical Center, who is an adolescent medicine specialist and who we were lucky enough to learn from in person in May. This hour is going to be dedicated to learning about Papilloma virus and adolescents. So we're going to learn about disease, about prevention and treatment, and ways that you can interact with your clients and other service providers around messaging and treating. So,
Sarah, hi everyone. Nice to be with you again. We'll get started here, and we should have time for questions at the end. So again, just would like you to let know if you are joining, and if you haven't done the roll call, just shoot her a quick email or type into the text box, and folks will get a post-test after presentation. So we're going to talk about human papilloma virus today, a bit about what it is exactly and what it can cause. Also, describe briefly how we diagnose and treat HPV infections, and address a little bit how we prevent HPV infections. And I've tried to adjust this talk and gear towards you guys as the health educators, you in your prep work. But if I go over anything that you find a little bit difficult to understand, feel free to just take some notes and then answer questions at the end. So, human papillomavirus. This is a picture of it. It is a pretty highly researched type of virus, of which there exist over 100 types. It's a member of a group of viruses in the genus Papillomavirus. Take you to your last days. They said there are over 100 strains, and of the 120 strains that exist, more than 40 of them are sexually transmitted and can infect the genital area of males and females and some other areas also. So when we look more closely at these particular types of HPV virus that can cause infection, we classify them into really high-risk strains, those that we know cause cancer, and those that are more low-risk strains do not cause cancer but do cause genital warts that we will see in our clinics from time to time. So HPV cause, well, people can be infected with HPV, actually have no symptoms. So, you know, there's nothing really to show for it, although it could still be transmitted. There is something to show for it. The low-risk types most commonly cause genital warts, but can cause a little bit of low-grade cancer. And then the high-risk types can cause what we call a high-grade cancer. Transmitted, well, skin to skin, mucosa to mucosa, can be transmitted via body fluids, and there can also actually be auto-inoculation, meaning someone might have an infection at one site on their body, and if they touch it and then touch another site, they might auto-inoculate themselves at their site. And how many is there out there in the world? Well, it's the highest incident sexually transmitted infection in the United States. Right? So the approximate prevalence in adolescents and adults is a 9.2 million. And by age 50, at least 80% of females that have been studied will have acquired genital HPV infection at some point, although many of them will clear it on their own. So the Disease Control, or the CDC, keeps track of numbers regarding a lot of infections, including sexually transmitted infections. And this is an estimate from 2008, estimated number of new and existing sexually transmitted infections. You can see that syphilis is on the end there on the left. But the total number for HPV is 79,100,000. So it is out there and everywhere. A few numbers that we have from studies give us an idea about who HPV is a little bit more prevalent in. So one study of just females, age 14 to 59, they really saw a peak in the high-risk type in those that were around 24 years old. And another study of males, 18 to 44 years old, again, there was more of a peak in the late 20s. In another study of males, 18 to 70 years old, where they were just studying actually HPV in the area of the rectum or the anal canal, there was a peak again in their late 20s and into their 30s. And then in a study that included both males and females, 14 to 69 years old, they took a closer look at existence in the oral cavity and saw peaks in both the 20s and 50s, and found a bit more in males than in females. These are, isolated studies done in different locations with different populations, but gives you a little bit more of an idea about what age groups the active HPV infection is seen. So some of the risk factors for contracting HPV, and this is a variety of information that's been elicited from different studies over the years. So you are a little bit higher risk if you are under 25 years of age, high risk if you had sexual debut at under 16 years of age, if you had multiple sexual partners versus 0 or none, and then if you have a partner a sexual partner has had multiple sexual partners themselves, you also can be at high risk. So just talk about first. So genital warts are often asymptomatic. So if you have the strain that can cause them, you may not actually have warts showing, even though there's a capacity for warts to show. Even when you do have genital warts, if you don't note them physically in terms of sensing them on your body or touching them, they won't necessarily cause you any pain or discharge that might otherwise alert you to the fact that you have them. Types of infections that are most common for the genital warts caused by HPV are those sites or areas of friction. So in people with penises, that includes the penis, the scrotum, the urethral meatus, or the opening at the tip of the penis, and the perianal area. And in females, the introitus, which is the opening to the vagina, the vulva, the skin around the vagina, the perineum, that area between the vulva and the perianal region, and the perianal region. And this might include, in terms of vulvar warts, some pain with sex, or possibly some itching and burning. That depends on the extent of them. In terms of symptoms on the penis, some itching. Area of the urethral meatus, which is where urine comes out also, there might be some difficulty with urination or some blood in the urine. In the vagina, there might be some discharge and bleeding, because warts can be what we call a little bit more sort of friable, get irritated or infected. In the perianal region, again, maybe pain, bleeding, or itching. In the cervical region, which the tip of the cervix up at the bottom of the uterus, top of the vagina, you might have irregular bleeding or some bleeding after sex. But again, you might not have any of these symptoms. Can vary depending on the HPV virus and how it's manifesting itself. So no need for you to pay a lot of attention to these words on the left, but having an understanding of what things can look like. So what we call condyloma acuminata tend to be sort of cauliflower shaped, so sort of rough, but flesh-colored or pink or darkly colored. They can also be smoother papules or bumps, so sort of dome-shaped and skin colors. You can understand how maybe someone would not know they have something like that if they aren't paying a lot of attention to their body. Can also something keratotic warts, which can just look a little deader and rougher and have a sort of thicker top layer that can look more like a common wart. And you can also have what we call flat papules, so flat, slightly raised, colored bumps with a smooth surface. So again, something that some might not immediately notice to have right away if it's especially flat and smooth. And this is when totally paranoid that any tiny bump they notice is a genital wart, because there are lots of normal bumps in the genital region, but it is important to bring it to the attention of someone if people really feel like it's something abnormal and have things checked out. I frequently in the office will have a young person say, "Hey, I noticed something odd down here. Can you just take a look for me?" And it's something that's not of the ordinary at all. So diagnose genital warts? Well, for the most part, it's a clinical diagnosis. We take a look, we know what it looks like, and we diagnose it. We don't do any sort of fancy tests, or we get samples from it, or blood tests. We can consider doing some sort of biopsy if the warts look strange and abnormal to us for some reason, or if we try some of the approved therapies and they don't work, or if they are bleeding a lot, or there are just other things we're worried about. Usually would work in concert with a dermatologist for those testings and to get biopsies. What do people like to know when we diagnose HPV, when they got it, who gave it to them? That can be a little bit hard to tease out. The incubation period for genital warts, so the time it takes from when you might have had transmission to when you actually have an outbreak can be anywhere from 3 weeks to 7 months. So in particular, if you're someone who's had multiple partners, it can be in the recent past, it can be hard to determine who transmitted the infection to you. It can persist for many months, and it's for everybody, and it also to a certain degree depends on your own immune system and how ease infection initially, and then how it helps your body sort of manage the infection. In treatment, our goal as clinicians, if the wart are bothering someone, is to help with removal, and one might want to get assisted removal for cosmetic reasons. It looks bad, they're embarrassed, any reasons, or it might actually be bothering them. So, something might be in a clothing where it's rubbed repeatedly and causes discomfort or causes bleeding. This is superficial. It doesn't get rid of the underlying infection. That's important to know. It's not really known if the periodic treatment of the actual warts actually will decrease transmission risk or not. And recurrence can be common, right? The other infection that we talk about in the body that have recurrence is herpes simplex virus. So you often will have an initial outbreak, and the active infection recedes, but it still lives in the body and can come back at another time. So for genital warts, 20 to 50% can recur in 3 to 6 months, actually. 10 to 30% will actually spontaneously go away on their own within 2 months. Yeah, different for different people. So one thing to try for folks are patient-applied creams. We will prescribe folks, and as providers, we also administer some treatments in our office. That might be something like a very simple little surgical removal using an acid, which sounds super, but cyclic acid or TCA is sort of a mild acid, which we apply with a Q-tip or another type of applicator. And then we can actually freeze them also, much like we do with regular plantar warts or warts you might get in your foot. I don't really have a lot of evidence that any method is superior to others. I think different providers have preferred methods, and patients, when they're offered treatment, have different preferences about how easily they want to be able to do something, so that they want to be on their own schedule applying cream at home, or do they want to have frequent medical visits. It just depends. Warts and partner implications, because when you diagnose these in someone, know they came from somewhere originally. You might have a case of auto-inoculation at a particular site, but you want to chat with folks about the risks of transmission. And many partners might have subclinical infection already, meaning they don't have the outward signs of infection like the warts yet, but they might have it. You don't do any specific HPV testing for partners. What you talk to people about is routine STI testing for the really common infections, like other infections, like chlamydia and gonorrhea. And if they've had previous STIs, you might recommend additional STI testing along the lines of syphilis or HIV, depending on the individual patient. So ending condom use, whether female or male condoms or dental dams, again, for that barrier protection, is important. And don't do sort of preventative treatment to prevent the wart from coming on. Oops, is that a question, or someone needs to mute themselves?
No, I'm sorry.
That would be
Thank
great.
You.
Oh. So, moving to some numbers about cancers attributed to the high-risk HPV type. The note here from the top of this chart, all vaccine details later, but the original HPV vaccines, the two virus type, that was the first to come out, just covered for the two main high-risk HPV types, 16 and 18, that causes most of the cancers. Now we have, I guess, a third-generation HPV vaccine that covers 9 HPV vaccine types, high-risk types. I'm sorry, it's a combination of high and low-risk types. It includes 5 additional high-risk types that cause a little less of the cancers, but nevertheless causes the cancers. So, to give you an idea of the type of cancers that the HPV is causing, the cervical cancer is the most common in females or people with a cervix, and oropharyngeal cancer is common in male-bodied people. And the difference between gray and blue on this chart are the number of cancers caused by those primary high-risk HPV types, 16 and 18, and the cancers that are caused by the 5 additional types. So you see we get some nice additional coverage in cancer prevention with the newer vaccine type that we have available. The high-risk HPV cause cancer. This is something that people continue to study. And I think I mentioned before that a lot of people with a normal immune system will clear their HPV viruses on their own over time, but for some reason, some of these high-risk HPV types remain in people's bodies, and they lie low for a while before they start to wreak havoc. And this is a more complicated picture of how the virus enters into the skin or the mucosal surface, and it burrows way down into what we call the basement membrane, then eventually starts to proliferate or replicate and cause problems. The description at the top describes, this is referred to as cervix in particular, so cervical infection. You know, going from left to right, we have a normal cervix with no cells and no problem. And then you can see how the cervix will look as abnormal as the virus proliferates. And when a medical provider does a vaginal speculum exam to take a look, for example, at a cervix that might be having abnormal bleeding, and we want to find out if there's any specific reason for it. For example, is there a sign of infection, or is there an anatomical abnormality? Is there trauma or something going on? When we see a cervix that has been seriously infected by high-risk HPV, you can see in this picture how that nice circular surface can look quite rough and abnormal and cancerous. So just for the progression, we searched for a while. So again, people will be at higher risk if they have a weak immune system. For example, people that might have active HIV infection and immunosuppression or other immune problems. That might be at risk for progression are those that have never or rarely been screened for cervical cancer with pap smears. And we showed that 50% of women in the United States with cervical cancer have not had a pap smear in the years prior to diagnosis. And I will get to details about pap smear recommendations a little later. At this for healthy people with cervix without any immune problem, it's recommended they get their first pap at 21 years of age. Older age can also be a risk factor. If that specific type, 16 or 18, is a risk factor, it's possible that people can be at higher risk when are tobacco users, pregnant, have nutritional deficiencies, other sexually transmitted infections, genetic predisposition. And is, in fact, is necessary to cause cancer, but you also need that persistence of infection that could cause that abnormal replication. So those types doesn't automatically mean you'll progress to high-risk cancer, but you just don't know if you might be that person. This is just tells us a little bit about HPV regression. And we used to recommend Pap smears at a much earlier age. For a while, it was with onset of sexual activity, no matter what age you were, then it was within 3 years of sexual activity. And so people went to a lot of abnormal cervices and recommend little procedures to evaluate what was going on. And what we found after a lot of research had been done, and I should wait because I didn't do the research, but I know all about it, is that a lot of these infections actually go away on their own because a normal immune system can fight them. And so we were screening and catching infections and intervening and maybe getting biopsies and things that weakened the cervix for no reason, because for a lot of these patients, the infection would go away on its own. So everyone sort of re-looked at all the data and information and decided they also were learning that if it's bad infection, it will progress slowly, that we could wait and do screening a little late in life. I hope that makes sense. It can be a little hard to understand the first time you hear it. Anyway, so if you take a look here, we have the blue line of HBV infection. So sort of initially, say someone contracted it initially at 15 years old, and if they happen to get one of the high risk likely to cause cancer, you can see how it would take a little time for that to develop. So even if they got infected in around 15, they didn't necessarily have signs of really bad infection until later around the time the Pap smear was due, and hopefully that would be done and it would be caught. But there are recommendations for routine Pap smears to continue to occur then as actually active person with the cervix continues to be at risk. And if the low risk type is going away, and sometimes high risk types will go away, it depends how long it takes for it to go away. Mean time to regression from a lot of different studies is about 8 months. And one study showed that 61% regressed in 12 months, so meaning went away, and 91 regressed in 36 months. But a certain percentage did study to the higher risk types and high grade. SI is a term we use when we're looking at Pap smears and looking at abnormalities of the cervix. And maybe I'm getting into too scientific gear for you guys, but move on to some other more basic stuff. I want you to have an idea, really, of how this virus works. So how do we detect cancers in folks? We recommend routine screening for cervix in people that have a cervix, and that involves getting a Pap smear for people with an immune system starting at age 21. There's been a lot of back and forth about anal Pap smears to screen for anal cancer, but we don't have any official recommendations at this time from the CDC and other scientific bodies. People in some will routinely do Pap smears, even though there isn't a huge evidence base behind it quite yet. So that is a thing that continues to evolve. And smear is basically when we evaluate for abnormal cells from a specific site. So a Pap smear for a cervix involves doing a vaginal exam with a speculum where we get a nice look at vaginal walls and the cervix, and we use now the technology is this soft, flexible sort of plastic brush with a point that we whirl around a couple times, and then we put it into a jar and close it up and send it off to the lab to be evaluated. It's a pretty straightforward process. So, and when we start Pap smears, it's many times over the last decade, so it'll be hard to keep up with, and especially when I'm dealing with young people whose parents are older, and for example, have a mother or an aunt who got a Pap smear when they were very young per previous recs, might be sent in to me, you started having sex, you're 15, it's time for your Pap smear, it's time for that alligator clamp exam thing, everyone, let's get excited. And they arrive, and we have a lot of great conversation about a lot of other things, but I let them know that they actually aren't due for a Pap smear yet, according to our newest guidelines, until they're 21 years old. And under 30, after you have your initial one, it's recommended that you get a pap smear every 3 years. And recommendations are accepted by a lot of medical groups, and they've been studied at length. Still, sometimes when I speak, if there's a cervical cancer survivor in the crowd, they tend to raise their hand and be a little freaked out, you know, by the fact that the screening recs are happening late. And again, that's just because, you know, when the infection is bad, even if people get it younger, it takes a long time for it to advance to cancer. And to the HPV vaccine a bit later. And I missed my clock. Oh, there it is. See how I'm doing? Okay. So again, the reason pap smear recommendations were changed is that a lot of infections are transient, but when they're not, it can be a big problem. So that's why we still prefer to screen. Some of them are some clinical and have no clinical consequences. So even though we have high rates of HPV in young adulthood, remember those numbers I talked about, how a lot of the high-risk infections peak in the 20s. We know younger patients are less likely to have persistent infections. The infections progress slowly, and invasive cervical cancer at less than 21 is really rare. And when we do pap smears and find abnormalities, it can lead to a lot of different little procedures, which can have side effects, cause a lot of anxiety, and may not have that much benefit. Vaccine we'll talk about next, and this is just some key points of it. Prior to sexual initiation, we know the earlier someone gets the HPV vaccine, the more likely they are to build up a large amount of antibodies to help protect them from infection. And our official recommendation is that people get their initial HPV vaccine at the 11 and 12-year-old and pediatric or family medicine offices. There's an enormous potential for disease prevention with the HPV vaccine in terms of preventing wart cancers. It's effective. The government never recommends anything unless it's cost effective. That's a big deal. And the vaccine protects against multiple strains, 9 instead of the 2 and 4 strains that it initially covered. What we have now is the 9-valent vaccine. It covers all these types, 11, 16, 18, 30, 33, 45, 52, and 58. It is recommended for young people ages 9 to 26. These are the only populations it's been studied in. Once in a while, you'll hear about advisors giving the vaccine to older folks. It won't necessarily be covered by insurance. But people don't go to jail or anything for giving it to people outside of the age range. This is just the age range in which we know it's most effective. Again, you can see that this vaccine covers 6 and 11, which covers 90% of genital warts, covers HPV 16 and 18 that cause 70% of cervical cancer. And then the additional strains in it also cause cervical cancer, but not as much. With HPV immunization rates, slowly better. This is a slide that shows other vaccines indicate that the 11, 12-year-old visits HPV. So Tdap is tetanus, diphtheria, and acellular pertussis, and Nactra is against meningococcal disease. Those newer vaccines with newer recs in the last decade to begin at 11, 12 years old, and those slowly climbs. People are pretty freaked out about getting meningitis or tetanus or diphtheria or pertussis. We don't see those much in this country anymore. But people have been more reluctant to get HPV vaccine for their children, and in most states, parental guardian permission is needed for HPV vaccine. In Georgia, California, it's minus right to confidentiality laws, so young people can come in and get it on their own, but not everywhere else. So we're doing better for girls than boys. HPV vaccine was approved for girls first, and we are at 60% of girls in this particular study getting at least their first shot, but much fewer are getting all 3 shots that they need. An important point to make is that we really recently had a change in number of doses needed for HPV vaccine. So it used to be that everyone needed 3 doses spaced apart, number of months. Now, if you are under 15, you only need 2 doses. But if you start your HPV vaccine series when you're 15 or older, you still need the 3 doses. Males were not doing as well. HPV was approved for males a little bit further down the line, and that's because male-bodied people don't have cervices, which, you know, are one of the main cancers that HPV causes. But HPV is transmitted between cervices and penises. And so the argument is that we want to protect everyone to improve levels of protection, but the complications in, you know, those with the penis are less so than those with the cervix. So we are working on this on a variety of fronts. The top 5 reasons for not vaccinating adolescent daughters, when parents were asked, a study put out by the CDC in 2014 was that they just didn't know much about it. So a lot of our projects with providers helping them to provide education to parents and guardians and young people. A lot of parents felt like the vaccine wasn't needed or necessary. There could be a voluntary thing. People also have had concerns for safety and side effects, so supporting families and providers in providing education about safety has been an important strategy also to work on increasing immunization rates. And people just didn't have it recommended even by their providers, because we have found that providers also actually didn't have a great knowledge base about the benefits. And then a lot of people thought, oh, the vaccine protect against something that's transmitted by sex, and a child not having sex yet might never have sex, so they don't need it. Again, as I mentioned earlier, the sooner you get it, the more antibody you produce. So the reasons for low rates that healthcare providers struggled with making strong recommendations and including the recommendations for this vaccine along with all the other vaccines they recommend quite freely. If they hadn't sort of trained or thought about introducing the concept of this vaccine as a cancer-preventing vaccine, think about it more as an STI prevention vaccine, which brings up the question of sex, and talking about sex with 11-year-olds can be uncomfortable, but that's really not what it's about, even though it's linked to it. People would often just present vaccine as an option. Oh, by the way, you could get this if you want, but if you don't want to, you don't really need to, versus getting, you know, a recommendation and providing sort of the evidence-based information about what it do to help improve morbidity and mortality. And know about fears around sexuality and sex in our country in particular, thought that if you talk about a vaccine that covers an infection, it's going to make people go out and have sex, right? Just like if you tell them to use condoms during sex and you give them condoms, they're going to go out and have sex. So people say this, and guess what? Just the HPV vaccine does not go out and start having sex. And this has been documented in a few different studies. Association with increased sexual activity. No association with number of sexual partners. So when you get the HPV vaccine, even if you have 1 or 2 partners, you don't go out and get 4 to 8 partners. It was interesting that when people were provided with education, they also reported they were 3 times more likely to report consistent condom use in one of the studies. So whether we're providing it in the office or you guys are inserting some of this messaging into your health education work, HPV really is about cancer prevention, although who doesn't want to prevent genital warts also, because they are not fun. The vaccine is more effective and produces more antibody in the younger age groups. It plays a role in adolescents to say about sex. And we have more deaths related to HPV disease and cancers than in this country than tetanus, diphtheria, pertussis, and Neisseria meningitidis, which can cause meningitis. altogether in the United States. And a little here for more info on HPV and some HPV resources at the CC website. And this is just an infographic which sort of demonstrates how far we still have to go to improve HPV vaccination rate. This is from 2014. The numbers are a little bit better now, but only 6 out of 10 girls had started the HPV vaccine series when the study was done in 2014, and only 5 of 10 boys had. Some additional resources if you are interested in looking any information up on your own. And to answer any questions or hear comments from folks, remember this is all being recorded, but no question is a stupid question. We hope that your colleagues that haven't been able to join us today will be able to watch this at a later time that's more convenient for them, as they all are. Those that aren't here, we assume they're working hard somewhere, so we're not holding this against them for not attending. And so I think you could either unmute your line and ask me a question, or you could type a question in, whatever you prefer. And no questions? We'll just a little early. That's our idea. There's an option for it, especially on the day.
I have a question, Laura Mack. If you had the earlier version of the one that was administered before the 9-valent, should you be revaccinated?
That's a question. No, you shouldn't be. That's not the recommendation at this point. But someone could be if they really wanted to, but it probably wouldn't be covered again at this point. Does that make sense? Yeah.
Yep. Thank you.
If you got, so if you had 2 doses of the 4-dose vaccine, of the 4-virus vaccine, and by the time you were due for your 3rd one, the 9-virus vaccine came out, it's fine, just get that 9-virus vaccine for your 3rd shot. You don't have to complete with all the same types of vaccine, if that makes sense. It can combo.
Yep. Okay.
Yeah, thanks.
Mm-hmm. All right. Well, as usual, you guys know how to reach us. Sarah, Tim, or I, and if you think of other questions, send them on through. We are working together on putting a little newsletter for you guys with some frequently asked questions. So if we have any other interesting questions that come through and answer them, we'll send those answers on to you guys. And so that's a nice segue into if you've got any questions from yourselves as educators or from the young people you're working with regarding any of these topics we've gone over in any of our sessions, please send them in, and we'd love to provide answers for those through our newsletter. And just a reminder that I'm available for some, individual technical assistance to different sites. 6 sites have engaged with me. That's a combination of prep sites and some clinical sites, but I have 4 slots still open. If you want a call or a visit to talk about anything, just let Sarah or Kim or I know. All right.
We'll talk again next Friday, so on June 23rd from 9 to 10. We're having our second webinar.
We're on trans issues. And keep an eye out for the post-test that's coming after this. All right. Next week. Thanks.
Bye.
Bye. Thank you.